Niagara Health is home to one of just a few interventional radiology programs in Ontario, providing specialized tumor treatment that requires minimal surgical intervention and also faster recovery for patients. We welcome Dr. Sriharsha Athreya to the studio. Doctor, this is world-class care happening right here in Niagara.
It's indeed, yes. These kind of treatments are evidence-based, well-known to the entire kind of global population. Many centers across Canada, North America, Europe, and Asia, they're offering these treatments. And we've been lucky that we managed to grow this program here at Niagara, so we can allow patients access to care locally, particularly for this, minimally invasive, as you said, cost-effective, least invasive treatment. They are performed as a day-stay procedure, meaning they get prepped on the day stay. The procedure or the treatment is done for certain cancers of the lungs, the liver, and the kidneys, particularly the small ones. Less than 4 centimeters is the kind of guidelines what we follow.
So this is going to be in earlier stages of cancer treatment?
Absolutely. Earlier stage 1 tumors, which are really small. And these are the patients who are not suitable for surgery because of their comorbidities, or the location of the tumor might be difficult to remove surgically. Or a patient thinks, well, why don't I go with this pinhole minimal invasive treatment and go home the same day and be on my golfing or in the garden the next day. So,
image-guided ablation therapy is really specifically what it's called, correct?
That is right. It's image guidance because interventional radiology is about image guidance technique. We use fluoroscopy, which is the kind of standard X-ray technique, CT scan guidance. We use CAT scan or the CT scan to guide the needle or catheter wire, what we use to the target.
The ablation aspect of it, you brought some props with you. Can we take a look? Can we take a look at this first? Can you explain to me what this is?
So what this is, a ablative treatment needle. It's the radio frequency ablation technology what we use. This is based on the heat technology. As you can see, this needle, it looks longer, and you might feel, oh my God, it's so long.
It does look kind of, very ominous.
That's right. So
but it's still better than opening somebody up.
Correct. So it's a pinhole incision in the skin, pretty much, to allow this tiny needle to get in through the skin into the tissues. We guide the needle under image guidance to the target, whether it's in the lungs, the kidney, or the liver. All these procedures are performed under local anesthesia and conscious sedation, meaning the patient pain is under control. They won't be totally off to sleep like general anesthesia, but enough sedation that they can have the pain relief at the same time, get the treatment done. And we get the needle into the target, and then if this technology, we have a lever to press, and if you can see, it opens up this tiny tines, what we call it.
And that applies the heat, which
that
helps
applies
to shrink
the heat
the tumor?
in the tumor, and the tumor cells die when the heat reaches about 50 degrees centigrade. But actually, the temperature at the tips of these and along this kind of wire kind of thing is about at close to 100 degrees.
Wow.
So the tumor cells die.
Now, alternatively, you brought this in as well, and that's the opposite end of the temperature spectrum.
That's right. So we got 2 technologies, a heat-based and a cold-based technology. Radiofrequency ablation, as I said, that's the heat-based. Another technology which also we're lucky to have that too, is the microwave ablative equipment. That's also heat-based. What this needle is the cold technology or the cryoablation. In this case, the technology is that it freezes the cancer cells at the tip of the needle to about minus 120 to 140 degrees, and that's what it kills the tumor cells and gets treated.
In which circumstances would you freeze? In which circumstances would you heat?
And that's a very good question, actually, very good question. So it depends on a couple of factors. One, how big the tumor is. Is it 2 centimeter? Is it 3 or 4? We usually tend to go less than 4 centimeter. The smaller lesions, we tend to go with the radiofrequency ablation. A little bigger, meaning something which close to 4 centimeter, we tend to go with a cryoablation because they tend to offer a better local curative treatment compared to the radiofrequency ablation. And also this it depends on where exactly the tumor is in the organ. Is it close to a vessel? Is it close to much deeper? It depends on couple of factors where we choose one over the other.
Right.
But as far as the oncology outcome is concerned, they're pretty much similar on par with any of the surgical techniques as far as the 5-year disease-free interval is concerned.
5 years is about how long this has been happening here in Niagara?
In Niagara since about late 2018, I would say.
And how many patients have undergone this ablation treatment?
So far, I'm told close to about 130 to 140 procedures we have done on patients. It could be maybe 120 patients. Some of them we might have to repeat. Maybe it's a bigger lesion. We might have to do it a couple of times. But I would say around 120 to 130 patients in the last 3-4 years in Niagara Health.
What kind of feedback are you getting from some of these patients who have undergone this?
Yes, so I think we've got very good feedback, both from our referring clinicians as well as the patients. They're very happy that these patients can get treated locally in Niagara. I know during my days in Hamilton, we used to get these patients being treated in Hamilton. It's quite a journey for them to travel. I know for some of them used to make a hotel room booking and stay overnight, whether coming from Fort Erie or Port Colborne. It's not easy. Or they have dependent on somebody to take them. That person has to, if he's working, apply leave and things like that. Now it's locally offered care, and we get really good positive feedback from patients and our referring physicians.
It's amazing this is happening right here in Niagara. Do patients consult with their oncologist about what treatment is right for them?
That's right. So how the process works is if it's a kidney tumor, usually the patients have their initial consultation with the urologist. Then if the patient's deemed suitable for these kind of procedures, we have a multidisciplinary rounds with our urology colleagues, and we select patients based on the rounds outcome. Then the patients are offered treatment after that. Similarly, if it's a lung cancer, the patients are seen with the lung DAP assessment center in the Niagara Health, and then these patients refer to us after that. And likewise, the liver tumors, we have a hepatobiliary rounds happening in Hamilton, which we log on to virtually and discuss these patients, subset of patients who are suitable for this kind of treatment, and then the treatment is offered after that.
Doctor, this is fascinating. Thank you so much for filling us in today.
Thank you, Mike. Thank you very much.